Hello again. Thank you again for the invitation. I will speak about pneumoperitoneum. Let's start my presentation, please. And you ask me the history of pneumoperitoneum and actuality. So, of course, if we speak about pneumoperitoneum, we speak about loss of domain. No. Okay, I don't know why. If we speak about pneumoperitoneum, we speak about loss of domain. And let's go to the history. So the first publication was produced by Goni Moreno from Buenos Aires in Argentina. The first procedure was in 1940, and he published his results in 1947. And I had this publication, and I want to show you today in the first part of my talk why I think that Moreno was a pioneer about loss of domain and pneumoperitoneum. And to explain why I think Moreno was a pioneer, let's back to the physiology. You know, during loss of domain, we can find the division of the linea alba. As a consequence, we will find the sagittalization of the rectus abdominis muscle as shown in the original drawing of Reeves and as shown on this CT scan. But also we will find the retraction of the lateral muscles as shown here. And as a consequence, we will find the progressive increase of the incisional hernia volume. Due to the intra-abdominal pressure and thanks to Pascal principles, and due to the diastasis, sagittalization, and retraction, we will find an open double door. The abdominal wall acts like the door of a saloon, and due to that, the hernia content gradually enlarge, and Reeves speak about a second abdomen. And finally, and as a consequence, we will find the significant reduction of the intra-abdominal pressure, leading to the diaphragmatic descent, progressive diaphragmatic paralysis, and respiratory dysfunction. That is to say, the restrictive lung disease, when the total lung capacity is less than 80%. All these physiological considerations explain why the loss of domain is so challenging. And the pneumoperitoneum acts against all these physiological features. So the pneumoperitoneum allows the reduction of the sagittalization, it allows the reduction of the retraction, but also it allows the increase of the abdominal cavity volume and the correction of the hypopressure. But also the pneumoperitoneum acts against the diaphragmatic descent, so we can find the diaphragmatic ascent. It is the preoperative correction of the lung disease, and the reintegration of the hernia and the retroperitoneum, as you can see here. And at the beginning, I thought that all these considerations were described later, but thanks to Miguel, and thank you again, Miguel, he gave me the original publication of Moreno, and in fact, Moreno has already described all what I have said just before. So here is the first publication, and he spoke for the first time about the disproportion between the abdominal volume and the visceral content. He spoke about the second abdomen in this publication, and he spoke about the loss of domain. He called that the loss of domicile. And he also explained how the pneumoperitoneum acts during loss of domain. And he explained that the pneumoperitoneum allows the reduction of the herniated viscera using these two drawings. He explained that in 1947. It also said that the PPP increases the abdominal cavity, and then he explained that thanks to the pneumoperitoneum, we can perform no suture tension in the midline with anatomical reconstruction. So for me, he is a pioneer because he described all these things 25 years before Reeves. And it was very impressive. What is his protocol at the beginning? When he published his first publication, he had performed 300 procedures. He explained for the first time, I think, about pre-optimization, because all his patients has an active respiratory physiotherapy, and he explained that the weight loss for his patient is very important. And it's funny, he says that the patient must be fasting with daily rectal enemas during 4 days before the first session. And he explained that the procedure should be done under local anesthesia with spinal puncture needle, and he explained this special sensation like this when he entered the peritoneum. He also explained that he used a Richardson insufflator. Actually, I use, of course, a syringe with a micropulse filter, but he used that device, and he used at the beginning oxygen. His protocol, it is 1 liter every 1 minute and a half. And the insufflation should continue until uncomfortable distension, pain at the side puncture, pain in the whole abdomen, or pain to the left shoulder. He explained that his protocol was 4 to 6 sessions during 2 to 4 weeks. And the last session, he called that the extraordinary amounts, because in the last session, he insufflated 8 liters in the patient. At the end, he controlled the tolerance of the insufflation with spirometry. As you can see, this protocol was very interesting and funny, because it's exactly what I do, actually. Not the enema, not the oxygen, but it's only what I do. He says that the surgery can perform under local anesthesia, but he also explained that it's preferable under general anesthesia. And at the end, he explained that the pneumoperitoneum facilitates the dissection. So that was the first part about the history of the pneumoperitoneum. Now you ask me the update. So during 50 years, not much publication. It was used empirically, 82 publication using PPP, mostly case report, and 2 large series coming from Spain. And in 2004 and 2010, it was the beginning of the objective evaluation of loss of domain, using of course volumetry and defining ratio. Tanaka published his method with ellipse volume, and Sabag explained that he used dedicated softwares, and they defined with Delphi consensus that the risk of reintegration in 20%, it is the ratio indicated for the preparation with PPP. After that, since 2011, some objective measures of the PPP effect were published. In particular, we published that the PPP allows an increase of the abdominal cavity volume as high as 53%. And the team of Amiens is a descendant of Stopa. They published in 2011 that the PPP allows a significant extension of the anterolateral muscles with a mean gain of 8 centimeters per side. After, in 2020, the team of José Bueno from Spain published the first review using the pneumoperitoneum. They included 28 studies with more than 1,000 patients, and they report 86% of complete fascia closure. So for 90% of patients, the PPP alone was insufficient, and component separation should be added to the procedure. We published similar results in 2016 with 80% of complete fascia closure without component separation. But for few patients, the pneumoperitoneum is insufficient, so something should added. And of course, in 2017, the first publication about Botox and PPP was published. I don't want to speak about Botox, of course, but since 2017 until now, several studies are published. So as you can see, pneumoperitoneum is very actuality, is not past. And until this publication, including 100 loss of domain. And at the end, in 2022, this year, the first review and meta-analysis was published using Botox and pneumoperitoneum for loss of domain. And the author report a 94% of complete fascial closure, but component separation were required in most cases. So they report a very good rates of closure. adding the two techniques is safe, but it doesn't prevent component separation for few cases. So what is the real effect of adding pneumoperitoneum and Botox? We published last year that including 40 loss of domain, some patients receive Botox and pneumoperitoneum, some patients receive only pneumoperitoneum, and we report that a similar increase of the abdominal cavity volume. But when we use Botox, we will find few postoperative complications. So our conclusion were that the association of Botox and pneumoperitoneum doesn't add any advantages in terms of volumetry. It doesn't prevent the need of component separation, but it decreases the SSO rate. That's explained that it is our protocol, and we always add for all our loss of domain, Botox and pneumoperitoneum, of course, and all the team repairing loss of domain uses always Botox and pneumoperitoneum. So the last updates and the last slides of this presentation is the algorithm. The objective is where is the pneumoperitoneum, where is the place of the pneumoperitoneum, and where is the place of the Botox. Frederick Beroud from Belgium published his algorithm, and he used pneumoperitoneum for all his loss of domain, of course, and he added always the Botox. José Buenoledo from Spain also published his algorithm, and he also used the pneumoperitoneum and the Botox in all his loss of domain cases. It is our protocol, our algorithm, and we also use the Botox and the pneumoperitoneum for all our loss of domain, and we know that for 10% of our patients, it won't be sufficient, and we will add some component separation. It is the last update, the history, the last update, and I think the future, perhaps, can be the fasciotense, because fasciotense was published last year, including 20 loss of domain, only BTA and fasciotense, 100% closure. So I think we should evaluate prospectively for loss of domain this device and to find the place of pneumoperitoneum, Botox, fasciotense in the algorithm in case of loss of domain. My conclusion? In case of loss of domain, there is a consensual objective to avoid any bridging and any component separation. The preoperative pneumoperitoneum for all loss of domain can be all what surgeons are doing actually, because there are physiology effects initially imagined by Moreno and proved after. Botox is easy, few invasive and safe, so it's always used in addition to PPP, and together 94% of the loss of domain can be closed without component separation. The real additive effect of pneumoperitoneum and Botox are to be proved, and my question is, can fasciotense reduce the rate of component separation? And actually, I think we should add all our patients in the registry or prospective studies. Thank you for attention.